Hello, my name is Valerie Moreno Sanchez, and today we are going to talk about FAST, short for Focused Assessment with Sonography in Trauma. And since we have already talked about abdominal trauma on Tuesday, now we're going to look at how to manage it in the ER. And because abdominal trauma is often related to intra-abdominal organ injury that can lead us to intraperitoneal hemorrhage or pneumothorax, for example, and today we're going to see this exam that is a very quick, reliable, and accepted exam that allow us to identify any intraperitoneal fluid. So this exam has an acceptable sensibility 69 to 98% for the detection of the free fluid in the abdominal cavity, but it has a lower sensibility 63% for a solid organ injury. So this exam may lead to underestimation of injuries and the severity of it, especially in stable trauma patients without detectable free fluid. On the other hand, this exam has a very high specificity, 94 to 100% for the detection of this free fluid or solid organ injury. So first, the reason why this exam is very important is because it enables the clinician to rapidly screen for an injury at the bedside of the patient, especially those patients who are too hemodynamically unstable or hypotensive to the transport to a CT scan, for example. So it is typically used in a patient as the patient's initial imaging examination at the arrival to the ER. Table I want to show you first the FAST exam that we are going to talk about today, also the CT scan and the DPL. DPL short for diagnostic peritoneal lavage. And I want to show you here that FAST is a non-invasive procedure, so it is better for you, for example, if you have an unstable patient and you cannot have the time to transport them to a CT unit. Also, it is repeatable, and so it is like you can repeat the exam if you are not sure, for example, if the patient has a intraperitoneal fluid or maybe you missed something, you can repeat it. But some of the disadvantages of it are that you can miss a diaphragm, bowel, or a pancreatic injury because these organs are not very easy to see in this exam. Also, it does not completely assess the retroperitoneal structures, and you cannot visualize the extralumen air. And here on the indications, you can see, for example, the DPL and the FAST. The DPL and the FAST exams are both indicated in unstable patients, but the CT scan is only indicated in patients who are stable. Now I want to show you an algorithm, but first remember that this exam was initially proposed to replace the DPL exam that we talked about before. And also, when you have an abdominal trauma patient, the first thing that you have to do is determine the location of the injury. Second, identify what kind of injury it is. And third, as you can see in these algorithms, so this algorithm is going to tell you that first you have to do the FAST exam independently if your patient is unstable or stable. But this algorithm is going to tell you first you have to determine if your patient is stable or unstable. So once you have already done the FAST exam, and if it is positive, that means that there is free fluid in the abdominal cavity, and if your patient is stable, then you have to do a CT. But on the other hand, if your exam is also positive but your patient is unstable, you have to take you have to take them right away to the OR. But this is going to maybe overdo some things. So if your patient is, for example, penetrating abdominal trauma, you have to obviously take them right away to an operating room. But if it is a closed trauma and you cannot determine, for example, the location of the injury, maybe you can do a laparoscopic exam first. On the other side, if you have a negative F.A.S.T exam and if your patient is stable, this algorithm is going to tell you that you have to just observe the patient and maybe repeat the F.A.S.T exam later. But as you can see here, this algorithm is going to tell you that also observation of the patient, repeat this exam, but also you can do a CT. But if you have an unstable patient and a negative F.A.S.T exam, this algorithm is going to tell you that you have to do a CT. But remember that if your patient is unstable, maybe you cannot transfer them to the CT unit, and maybe the patient is going to get more unstable on your way. But this algorithm is going to tell you that maybe you have to repeat the F.A.S.T exam. Maybe you did something wrong or you missed something. So this is why this algorithm has this part here that it is undetermined F.A.S.T exam. So if your patient is stable, you have to do a CT just to confirm to confirm where the injury is. And if the patient is unstable and you are not sure, you have to take them to an OR or do the DPL, for example. Now, we are going to talk about here how the machine is and how you have to select, for example, the probe. So here is the machine. And the probe selection in the evaluation of the trauma patient is dependent on what the main focus of the examination is going to be. So the preferred initial site of the detection of a free fluid in F.A.S.T is the right upper quadrant view that we are going to see later, scanned with a lower frequency sector or a curved probe. So this sector probe is a multi-purpose probe. So it is appropriate for examining solid organs and determine the presence of free fluid in the abdominal on the abdomen, or the pelvis. Also, you can use this to examine the heart for a pericardial effusion or hemorrhage, or for example the lungs, looking for a pneumothorax. On the other hand, you have the curved probe, and it is most commonly used in the abdomen for a better resolution, but it is not ideal for imaging of the heart or the lung that you're going to use the probe, the sector probe, sorry. So this is going to be less specific. Now, here are the quadrants that I've talked about before, but this exam is going to allow us to identify free fluid within three principal cavities. First, the peritoneal cavity or the intra-abdominal, so that you're looking for a hemoperitoneum, for example. So you have the right upper quadrant, that is this one here, the left upper quadrant, and the pelvis. Here, those views are going to allow you to look up the abdominal organs. But also, if you are looking, for example, for a hemopericardium, a cardiac tamponade, or maybe something in the heart, you're going to look at the subcostal window, or there is another way to name that, that is the epigastric region, or the subcostal four-chamber view. Also, if you're looking, for example, for a hemothorax, you're going to look at the costophrenic recess, but this area here, you can also look at them in the upper quadrants view. And if you're looking for a pneumothorax, you can also see them in the anterior chest wall. So since we're here talking about abdominal trauma, I am not going to talk about the pneumothorax or the hemothorax here. I'm just going to talk about these 4 points, and now we're going to look at them more specifically. So first, we have the epigastric view, or also named a subcostal four-chamber view. So first, what are you going to place the probe? The probe is going to be placed, or maybe in this picture is going to see better, just inferiorly to the xiphoid process. So here is the xiphoid process, and you're going to press the probe there. So what are you going to see? So this is an illustration that for me it is like better for the understanding of the anatomy. You're going to see the heart, the pericardial region, some of the liver, and also the lungs, but the lungs are not going to be seen very clear. So for example, if you have a hemopericardium or a cardiac tamponade, remember that the liver is going to act as an acoustic window to the heart. So beyond the liver, maybe you're going to see it better here. So this is the liver, this is the 4 chambers of the heart, this is one lung and this is the other lung. And remember that beyond the liver and the heart, there is this bright echogenic structure that is representing the pericardium. So it is normal that you just see this line. And also remember that, for example, if you have a shock patient, you also have to analyze the contraction of the heart, the sizes of the chambers, for example, comparing the left one to the right one, looking, for example, for a hypertrophy of the heart. But as you can see here, this is the liver and this is the heart. So here is a very large black region that is separating the 2 organs. So this means that you have a cardiac tamponade. So if you have black in a space between 2 organs, that is going to mean that there is going to be fluid, and it is normally blood. And this is how you're going to see the heart. Remember, this is the pericardium, so you have to look at it first. And also the contraction, the sizes of the chambers. Yeah. Going to see the right upper quadrant view, that is this one here and this one here. So you're going to place the probe on the right mid-axillary line, meets the costal margin here. So this is also a illustration of the anatomy that you're going to see. So the first organ that you're going to see is the liver, and also the right kidney. Remember that the renal appearance is a double density, and it is very easy for you to recognize it. So what are you going to look here when you are doing the exam. Mainly this recess here that is between the liver and the kidney. This is the hepatorenal interface, also known as Morrison's pouch. And this recess has been shown to be the most common region in which hemoperitoneum is detected during the FAST exam. So, since the predilection of the fluid is to collect in the right upper quadrant, it is the first view that you are going to be detecting or performing during the FAST exam. And also you can see here the perihepatic area, but remember the Morrison's pouch here. So this is what you're going to see on the exam. So here is the liver, and here is the right kidney. So as you can see, it is very easy to recognize. And this line here, this white line here, is the one that we are talking about. So this is the normal view. You can see here that in the pouch, in the Morrison's pouch, there is blood or fluid, free fluid in the abdominal cavity. So this is a positive study in anechoic appearing blood. We pull at the interface and create the black layer that separates these two organs. So this is what you're going to see in an abdominal hemorrhage. And this is what you're going to see when you do it. This is the liver, and this is the kidney, and here is the Morrison's pouch. Now we are going to look up the left quadrant, the left upper quadrant view. That is this one here and this one here. You're going to place the probe just exactly as you did in the right side, but more posteriorly. So in this illustration, we're going to see, so the first organ that you're going to see is the spleen. Also, you are going to see the left kidney, and this kidney compared to the right one. Remember that it sits higher on the left side, and structures are more cephalid, and some adjustments of the technique are required. As I told you before, you have to place the probe more posteriorly. Yeah. And also, so here, what are you going to look at? You're going to see also the costophrenic angles here, and I forgot to tell you before that in the right upper view, here you also can see the costophrenic area, looking for a pneumothorax, for example, but it is not well viewed here, as you can see. So you can see the costophrenic left region here. Also, you are going to see the subphrenic interface and also the splenorenal interface. So this is the splenorenal interface that is going to be very common for you to see blood here, and also the subphrenic interface. So this is how you're going to see it. Here is the spleen. Remember that the spleen is shorter than the kidney, than the liver, obviously. So this is how you can also differentiate them. And you're going to see here the splenorenal interface that I've told you before. And this is how you're going to look at it. Spleen, kidney, and the interface here, the line, the white line that is between those two organs. Now, finally, we are going to talk about the suprapubic view. And as the name says, you're going to place the probe in the suprapubic area. And remember that you can place the probe in two ways. First, horizontally or vertically. Here we're going to see, well, this illustration is going to illustrate us how you're going to see it in a vertical position. So remember that the pelvic anatomy is very important here. So in males, that is this illustration, you're going to see the bladder. That is going to be a huge black area, and also you can see some of the rectum or the intestines here, the bowel. So this image is going to represent how you're going to position the probe horizontally, and so this circle is the bladder, and this is a male patient. So here is some anechoic fluid collecting in the rectovesicular space, and also this means that we have free fluid in the pelvic area. But on the other side we have the woman's image. So here is the bladder, here is the uterus, and this is the pouch of Douglas. Remember that it is physiological normal if you have up to 50 milliliters of fluid in a female patient, but if you have more than 50 milliliters here in this area, it means that we have free fluid in the pelvic area. So the pouch of Douglas and the uterus here. And this is how you're going to see it on a vertical position of the probe. So here is the bladder, and you can see some bowel here, and you have to look at this region. This is a male, and you're going to look at the retrovesicular space here. So finally, remember that this exam has some limitations. So for the abdominal examination, detection of a blunt mesenteric bowel, diaphragmatic, or retroperitoneal injuries can be very difficult to see, as well as an isolated penetrating injury in the peritoneum. You can also have some false positive scans may result from the detection of ascites, ventricular peritoneal shunt outflow, ovarian hyperstimulation, and ovarian cyst rupture, etc., that is going to make us think that there is an hemorrhage, for example, but there is not. Also, although free fluid detected in this exam is assumed to be hemoperitoneum as blood, you can also see some injury-related urine, bile, or a bowel contents. And finally, remember that some bowel gas, subcutaneous emphysema, and obesity can represent the most common obstacles of the full visualization. Also, patients with delayed presentation after the trauma may have hemoperitoneum containing clots, which can be mixed. Echogenicity and this one can be missed. Also, perinephritic fat, which widens the hepatorenal and splenorenal interface, may be misinterpreted as a free fluid or a subcapsular hematoma, also known as the double line sign. So In these cases, you have to compare the two views of the kidneys. Thanks a lot.